And thank you for such a rejuvenating start in the morning itself. And good morning to you, all of you. It's a pleasure to be here. And I really thank you all to be part of this panel discussion. And it's quite early in the morning. And glad that all of you could make it. For this panel discussion on revenue cycle intelligence, we have got three eminent panelists. We have got Dr. Sumesh Mittal, who is the Managing Director and CEO of Vikram Hospitals. We have got Mr. Manish Mehta, who is the Group CFO of Birla Hospitals. And we have got Mr. Johar Sabuwala, he is the CFO of Reliance Hospital, Mumbai. This topic on revenue cycle intelligence, I think it's a very important topic because we come across a lot of hospitals who are doing operationally well but still are under financial stress. And one of the key reasons is that they are not able to manage their revenue cycle very well. Just to give it a quick start, let me start with posing a first question to Dr. Somesh Mittal about what are the financial drivers of a hospital's health, and in your opinion, what role does the revenue cycle management plays in that?
So, I'm Dr. Somesh. I've been heading hospitals for the last 25 years. I'm a medical graduate and then done my MBBS. I've done my MBBS, MS, and I've done training in open surgery. So I have a knowledge on the clinical side, and then I moved on to the other side of by doing my MD and now practicing as a district. So for me, I think the healthcare, if you ask me the revenue cycle management, what is important is where we get revenue from is the clinical specialties which we practice. So that's how we get the revenue. So what is important is how we get our top line. In the layman's language, and thing is that how you get a top line and then how do you manage your middle line costs so that you come to some kind of a profitability. Why cycle to my mind has become important now is because of involvement of government to such an extent that they are trying to streamline some of the costs which were being overcharged in the past, if I put it rightly. And now the things have become more difficult for the private hospitals to work out how to still continue to maintain a profitability. So I think what is important is to have the right pricing in place so that you are maintaining a top line which is good without compromising the overcharging and others. And second is how do you ensure, which has become I think more important nowadays, is how do you manage your cost. What is important now and going forward to my mind will be that you are continuing to manage your cost without compromising the quality. So second bit to my mind is more important than the first bit. What is in hand of any hospitals is to manage their cost. I think it is difficult to predict and tell that this is what I will do my top line revenue. We keep planning, we keep budgeting, but at the end we are not sure. But what is in our hand definitely is our cost angle which is there. When we talk about cost angle, everything is there. Manpower cost, to power and fuel cost, to marketing cost, to material cost, to pharmacy cost. So that is something is in the direct control of the team of hospital, both clinicians and non-clinicians. So I think that's what.
And cost is definitely a very important area. And that's revenue cycle management. Is that also very important for the hospitals, or would you say that compared to cost, of course, it's not as important? Because personally, during our consulting engagements, we have come across many hospitals who are doing pretty well on the top line, but because of their revenues getting locked up in different schemes, they are in such a stress that they start, suffering on that part.
So when I'm talking about cost, I was meaning in that one front is that definitely what you are talking about, Sumit, is on cash flow item which is there. So one is that if you maintain your cost, a lot of cash flow will be there, you will be saving it. Second is also important is what mix you take it. When we are talking about mix, which we are talking about panels like government panels which are there, or some panels which are there where you don't get your money on time, it gets blocked. So on the paper you have the money, but in reality you don't have the money to run it. So your cash flow is tight. So you cannot be giving the money. So what you end up doing is you stop paying the vendors on time. So in the end, what happens is your cost of procuring those items becomes high, because then vendor does not give you a good rates for it, because he says you don't pay me in 30 days. So what is important for us to have a right mix of those not so timely paying versus those who are paying. So what we need to do is, many hospitals end up doing what is that we end up taking a lot of panel patients to just fill in your top line, resulting in having a top line on papers, but you don't have cash in hand. And that is why we should definitely work out of managing. Simple formula which I work on is that you should not have more than 15 to 20% of those panel patients in your hospital, is what I feel as a mixture, so that you are able to have cash in hand with you. So that target we have to keep completely control on it, so that your receivables does not become a problem and you don't end up into a problem.
Yeah, coming to you, Johar, and so that the receivables do not become a problem. So what are the normal issues that the hospitals face? What are the holes through which the entire revenue cycle management process starts, creating a problem for the hospital? What are the common challenges that you face?
I think I agree to what you just said. I mean, you need to be wary about your, customers and what segmentations they are. There should be a healthy mix of self-payers, TPAs, insurance, government payers, and so on and so forth, so that you are completely in control of where the cash is going to come from. Of course, having self-pay patients more and more is the best, because your order to cash is the shortest. But I know for sure that even TPAs and insurance companies are now working hard, especially the private ones, to ensure that the claim to payment ratios reduce. So I know that ICICI Lombard and companies like HDFC are now having KPIs for their teams on disbursal of claims. So within 7 days or within 3 days, now they are targeting, so that their teams can negotiate better deals with the hospitals. They can reduce that turnaround time. So that's something that one needs to also see, whether giving the cost pressures that the company may have, what kind of customer base and what kind of proportionately how you want to divide your targeted patient base. So that's going to be important, I think, as far as managing the bottom line and cash flow, as the rightly said, is concerned. And with more and more pressure from the government, the margins are going to be under pressure. And so all the more important that you ensure that your revenue cycle is tighter and compact, and you have a tight leash on that kind of a process and people.
Manish, coming to you, this entire revenue cycle management requires a lot of coordination within a hospital. Operationally, it's quite complex because you have a number of policies, different level of coverages, not a single uniform way of filing the claims. There's no standardization there. Given this operational complexity, there's a chance that something will not go right. The claims will get rejected. There will be a lot of queries. How do you operationally, what are the operational challenges and how do you manage those things?
Yeah, Sumit, very relevant question, this is. And, the healthcare revenue cycle, the goal of the healthcare revenue cycle management is to frame a process wherein it helps the organization to realize the amount on the payment in terms of against the patient care which they have provided on time and at the earliest possible. Unique about the healthcare revenue cycle management is that the bills and claims are being processed over a long period of time, and over that often it comes that claims go back and forth between the payer and the providers for months and months until you can pinpoint where the errors has been made and it gets resolved. So the cycle becomes longer, the payment cycle becomes longer. So for this, and once this claims errors in claim submission happens, a substantial challenge comes into tracking that claim throughout its life cycle, and unless you pinpoint the error areas which are happening frequently. So to my mind, Western countries, if you ask me, these challenges have been mitigated by the use of technology. However, in Indian scenarios, the manual process control is the way to come out of it, or otherwise you simply outsource your TPA desk. So TPA desk, once you outsource, your headache becomes relatively low. But however, manual process, if you talk about to strengthen manual process, I would say staff training is a key pain point areas for the organizations and the hospitals, wherein more than 70% of the claims are getting rejected because of the human errors, like improper coding, or maybe pre-auth is not in place, or the procedure done without approvals, or insurance eligibilities are not there. So addressing all those things, for addressing these things, there has to be some standardized process, standardized checklist, and apart from that, training has to be a key point wherein we should be taking care of all those things to minimize the claim and settlement cycle.
Johar, another challenge, I think, what we normally say is that the clinical systems and the financial system do not talk to each other. So even if you have an EHR system implemented in a hospital, they will require recording the clinical advice, clinical prescriptions and those things. But suppose there is a bedside procedure which is recommended by the doctor. It is used or not used, is it billed or not billed, something which is not, even if it is recorded in the EHR, it's not reflecting in the financial system necessarily. So given these challenges, like the two systems not talking to each other, do you think there are revenue leakages which happen during the course of the treatment which is significant in hospitals need to address and some ways to do that?
Sure. So I think, as he rightly pointed out, training is the key to all that you want to capture. So you need to be very clear that what kind of services your doctors, your nurses are performing on patients in the wards in ICU or wherever. I mean, outside of laboratory and radiology, because there you have got systems like RIS and LIMS which are there to track your order and where the samples are going and how it is flowing. So controlling and monitoring and capturing that as part of revenue is much easier. Whereas when these systems are not there, so segregation of duty is one thing I think that needs to be done as far as capturing those services are concerned, and training, of course. So doctors may not be necessarily the ones who are feeding that data in the HIS or the billing system, but you can definitely train nursing, in identifying the services that they in their wards are, generating and then monetizing them. And of course, recognizing them and non-monetarily or monetarily, I think also is important, because then you ultimately recognize that this department is doing the work and also billing the work. It's not just, of course, there are charitable hospitals who want to, give charity, and there is ways and means of doing that charity, after recognizing the revenue, but it should be done institutionally, not by individual nurses or doctors. So I think that's what the message is I'm trying to convey here. So that's important here.
Coming to you, Dr. Mittal, see, one of the normal challenges that most of the hospitals face, and something whenever we are speaking to the hospitals, one of the questions that they normally ask, for this entire revenue cycle management, whose responsibility is it? Whose responsibility it is to collect the receivables which are there, or even like when they're filing the claims are filed, on time. Because many times it says, it's a billing department's responsibility or the sales and marketing's responsibility. Who should be responsible for managing the revenue cycle for the hospital?
So when we talk about receivables, Sumit, is that every hospital usually have a team. So it can be an organization if there are multiple hospitals. So then there is a central team which is there, whose job is to. So how does it work? It works that at a unit level, everyone after a procedure is done. Let's say, for example, a TPA or a CGH or ECHS. Whenever those procedures are done, the patient is gone. After that, those papers are collected together, and there is a set by which it is collected. There is a team sitting out of each of hospitals whose job is to then collect, and then within 7 days send it across or something like that. So, and that is tracked by the each unit heads or the subordinates of the head to see that yes, on a timely basis, the reports is being submitted to the respective TPAs or ECHS office or CGHS. Post that, there are two kind of scenarios. Single standard hospital, there will be a champion within the hospital whose job is to go back there and make sure that everything is in place or not place, going back and forth. There's a lot of manual, yes, automatic also it can happen, but up to when in Indian scenario you don't go to those places, you have issues, right? So what you do is that each champion from single hospital, if it is there, that person goes, or if it is a multi-hospital setup which is there, then there is a central team whose job is to go there and make sure A hospital, B hospital, C hospital, how many claims have been sent there and what is the rate of it. And as you were saying, that one of the things is that how many times it goes you have sent a wrong bill or certain things are not there in it. So you have to make sure that you have to check that where it is happening, and then training is happening so that you don't keep repeating those issues ever again. So what is important is that there is a central team which is there. Definitely in most of the hospitals it directly reports into one of the verticals of the finance head which is there. So ultimate, things lie with the CFO and the finance head, which is there, but definitely under him there are teams which are regularly being monitored and checked that what is the claim ratio which is happening, how much we are getting back, how much is the reductions in it, which is there. So all this is happening. So that's a process across healthcare in my mind, which is followed with little bit changes which is there.
Yeah, I agree to what Dr. Mittal said. Though it's debatable in a couple of the organizations, if you will see, it's quite debatable that whether it should be this collection team should be reporting to the S&M or the collection team should be reporting to billing or finance. So, but you see, to my mind, it's more appropriate to take the who is going to owe the responsibility. So, owing the responsibility and accountability should be with the billing in the sense, someone might contradict to this also, but again, in my mind, why it should be with billing? Because once your claims are being submitted and it's sent to, because salespeople are always keen to bring the business to the hospital and organization. They are least bothered to see whether the collections has come in place or not. Their targets or their so-called things get achieved once the patient is inside the hospital. But whether the claims got realized or not, it's the finance again. Because finance person has to keep the financial health of the company intact. So it's their own responsibility. They should do this. Now, what happens is when billing person takes this responsibility, he is aware what is there in the invoice, what is wrong in the invoice. If he goes or collection team reporting to billing team, they get the idea, and when they go to corporates or government and they talk about the claims, they know that this is a medical query or this is a billing query. In case it's a billing query, they can resolve it ASAP, then and there only, or maybe. But in case it's a medical query, they will go back, coordinate with the medical team, and then again come back. So the coordination becomes smooth when it's a billing query. But on the other hand, if it's S&M people, what happens is they are not aware what is there in the bill, what's wrong there in the bill. They will not be able to take decisions. They will not be able to divert this and coordinate with the medical team because their focus is on sales. Their focus is to bring in the patient. So that's why the claims always gets delays. So now, to my mind, it should be billing team who should be owning this responsibility, and finance should be overall accountable for this thing.
So what we are saying is the billing team would be responsible for that. As a custodian of the cash flow of the hospital will be responsible for it in a way. Because finally somebody who can influence the process should take the accountability of that. And
so what we are saying is, what we are trying to say is it is not billing team or a sales or marketing team. See, all have their job in place. Billing team's job is to manage the hospital scenario. Same way sales and marketing, which have been created, is to go out and do branding for you, to go to respective area, talk about your hospital so that the customers from that, patients from that hospital prefer your hospital to come. Now, if you put sales and marketing on the job for collection, then trust me, the first job, which is to get more patients into the hospital, whoever needs a treatment, to your hospital is lost. Same way, billing person starts to focus on collections. So then, same is the issue. But what we are trying to say is that there is every hospital has a team whose job is for collection. Now that collection team has to report into someone. That reporting should be through the billing side to the finance team is what he is trying to say, and I totally agree with him. Reason being because a lot of things are dependent on bills being properly, presented or not. So that is what we are trying to say. So there will be a team which every hospital has it, whose job is to collect. So there is a person, there is a 1 or 2% depending on volumes what you have, whose job is to go in different areas. Their reporting is at 2 different places based on hospitals, but majority I feel is in the finance side because cash flow is managed by finance.
In one of the early comments that you mentioned that this process can also be outsourced. So are you seeing that kind of a trend where the entire revenue cycle management or the parts of it is being outsourced to some agencies, and how successful has that been?
To answer this, whether the revenue cycle should be outsourced to the hospital or not depends on various factors, like volume, like payer mix, if it's more cash or more government and TPAs. Again, the technology, the IT technology which is there in the hospital, in the organization, and again the amount which an organization would like to invest in the these advanced technology of AR management or revenue cycle management. So all these factors will determine whether we should be outsourcing this or not. However, the revenue cycle outsourcing is not the solution for all the hospitals. So it might work for some, it might not work for some. The study shows that the financial performance of a hospital lacks when you actually outsource the revenue cycle of an organization. And the data which shows that the hospitals which have outsourced their revenue cycle has got the higher denial rates and also the long collection periods. And that long collection period is as long as 109 days who have outsourced it, and as against who have kept it in-house, it is as low as 76 days. So there's the difference. It might be because of the focus the inside team has got, the in-house team has got to collect these dues. But again, on the other end, if you see, the outsourcing is on rise. Outsourcing is on rise, and 80% of the hospital leaders are thinking that they should be outsourcing this revenue cycle. Reason is that they want to focus more and more on the clinical outcomes and clinical care rather than focusing on the non-clinical part. So this is also one of the angles to be looked into. However, the financial performance and the commercials are the key factors to decide whether we should be outsourcing the revenue cycle or not. But to my mind, the hospital leaders should also think and evaluate a couple of advantages which the revenue cycle outsource gives to an organization. For example, lower the cost of operations in the long run. Again, the advanced use of technology for the revenue cycle management by the outsourced companies. And again, the amount of investment which they are willing to make, they can make it in the clinical areas rather than investing in this new technology, which is already that subject matter experts are having that as an outsourced agency. And again, the talent pool can also be centralized for this collection and revenue cycle management process. So these are the things an hospital should consider before and finalize whether the revenue cycle management should be outsourced or not.
So you're saying the experience, the data shows that if the revenue cycle management process has been outsourced, the number of days of receivables has gone up, possibly because of the lack of focus, etc. So that will bring us to the premise, why the outsourcing was done. Is it because that outsourcing provider was experienced and had the checklist and technology to provide that kind of a service? Because otherwise there's no case for outsourcing.
Yeah, so I think what he's trying to say is that if you outsource, there has been scenarios where the days actually gone up, not down. Why is that so? Because as he was also saying earlier, is that there's a lot of back and forth in settlement of the claims, their queries, and that's where the collaboration internally also comes in. The outsource agency may not know how to go about meeting with whom should they meet with, whom should they discuss with in settlement of these claims. So if the team is in-house, then that collaboration and that ecosystem can be developed much faster and cohesive than having an outside person doing that. So I think that's what the point was making.
To continue with you, if you look at the way the entire system works, there are a lot of TPAs, different formats, etc., different policies. So considering this entire thing, do you think the insurers, the TPAs, the hospitals, all of them should come together to have some common standards of so that entire data exchange becomes easier, the claim filing process becomes easier? What are the kind of changes that are required in the system as a whole to make it happen?
Yeah, ideally that's where it should be. But somehow, it's always in the interest of the insurance to delay the payments. So there will be ways and means of doing that, especially when you have a cloud like GIPSA, for example. And I wish that some of the insurance companies be part of these kind of forums so that we can dialogue and understand where the payments are. But unfortunately, I've never seen insurance companies representing any of these forums. So that's where their pressures are on increasing their policies, their products, sales, top line, as you were saying. So they are really least interested in ensuring that how hospitals will benefit. Unlike private players who are really competing against the PSC companies, and therefore it is in their interest to reduce the cycle and getting a better rate from the hospitals. Whereas with GIPSA, that game is totally different. It's totally one-sided. So I'm not really sure how much really that will convert into reality. But we can definitely work with private players and see how that data interchange and digitalization can be worked out. So that's my thoughts on that.
Just add to this, while we're talking about TPS and GIPSAs, I personally still feel that we don't have that much of an issue of getting the financials from them. Yes, there is a delay, but I think the major problems what hospitals face is the hospitals who go with the other panels of government, for example, CGHS. ECHS also is slightly okay. They pay you less, they pay you delayed, but GIPSA is in least of the even for cash flow comparatively. I think what is more important is that CGHS can equate. I may be wrong, but I feel Ayushman for that matter, yes, yesterday we were talking about saying that Ayushman rates are less, yes, that is one. But second, I personally feel the threat which private players face is that will there be again another CGHS into making, which means that timely money coming, I feel the private players, including me, we are worried of it, whether today it is coming, but what will happen after 6 months to 1 year when the 2 crore population will be, getting insured through that. That is the issue which is there. So major issue is on the bigger player of public sector, which is there, and I think that is what is important, which blocks your money. And what happens with the hospitals like single hospital which needs to push in their revenue, they know it that their money is getting stuck. But the tight balance between cash flow and showing your top lines and EBITDAs which are there, you are pushed yourself. You are hoping against hope of saying, so today CGHS is having a receivables of let's say 10 crores. So you'll get some 2 crores in next 3 months or 6 months. By then that 10 crores would have become 15 crores. So you are now in the soup. Whether should I disown this CGHS with 15 crores pending there, which may come, may not come. So after 3-4 months, you will get another 1.5 crores, you'll be happy you got some money. But your receivables have gone to 18 crores or 20 crores. So I think what is important for the hospitals is to be having a very tight control on themselves of those places where you don't get the money on time. You just get peanuts of money. First of all, it's very less, and then if you get it after 1 year or 2 years, and then also deductions of 10-20%, I think that is where administrators and financial leaders should put their foot down and tell them, no, let us stop this or let us not do. That is what my feeling.
Yes, so I just add on to that point. I think yesterday the CEO from the Ayushman was there, and probably that's the forum, and I was completely agree that if the government wants to really push the healthcare into private players, then they will need to not just increase the cost part of it, but also commit to reducing the revenue cycle. Only then the confidence from the hospitals will come about. I mean and what you were saying is is a bit relative, because in hospitals in Mumbai, for example, where hospitals in private domain may not necessarily engage with government agencies like there it is in Maharashtra, it is Mahatma Jyotiba Phule scheme or something like that. So private hospitals may not be having that kind of exposure, and therefore the pressure is really from GIPSA and not from schemes like state-owned schemes or. I mean, the realities in other states may be different, the hospitals may be different. So it all depends on which hospital you are from and which environment you are from. But yes, I agree. I mean, if universal health has to be reality, then revenue cycle ensuring the revenue cycle is managed well is something that the government will have to see.
So what it means is, that CGHS, ECHS or Ayushman Bharat, that it is not only from the pricing point of view, that is also from the receivables point of view. So that is again a very, very major area and major threats which needs to be addressed by the government as such.
And at least in Ayushman Bharat, at least since we are actually helping them implement in 4 states, they are getting a very positively mixed response. And when I say positively, it's that Ayushman Bharat is much better than the earlier government schemes. And there's a certain commitment that you get a certain percentage, and it's actually happening on the ground.
This was told by CGHS also by the way. It's again a government scheme, right? It will come in time, but it came for a few months and then it didn't turn up. So that's where the worry is that, in the mind, we are all stuck. And now, in GIPSAs, they don't have the same rules. What I know of is Mumbai, suppose my hospital bill is 1 lakh, and GIPSA pays you 50,000. Remaining 50,000 you are allowed to collect from the patient. So what does patient do is patient decides that I would like to go to Reliance or I would like to go to some other ABC hospital. I know the rate there is 2 lakh and there is 1 lakh. 50,000 is GIPSA, rest all I am paying from my pocket. Same is not the case in other places. In Delhi you cannot charge anything, in Bangalore you cannot charge anything extra. So I think what I feel is that the rules from the GIPSA side should be the same. It should be allowed in the similar manner so that the hospitals can decide. If my hospital is good, patient will walk into me. If B hospital is good, patient will walk into B hospital. That's what.
Johar, is it something which is very specific to Bombay, because the Bombay practices are very different as compared to other parts?
You see, GIPSA being a national entity, I mean, they really try hard and push all the hospitals so that the uniformity is there. So no more is the case that in Mumbai they are going to allow co-payment, and in some other state or some other city, small town, they are not going to allow. So I don't think that's the case anymore. There are some tremendous pressure from their bosses, and of course because it's a government-controlled entity, also from the government, that the standards are same across the country, not market specific or Mumbai specific, or so to say. That's not really there anymore. Yeah.
Manish, I know you are very passionate about technology. So where do you see a role of new technologies like artificial intelligence or robotic process automation playing a role in better managing the revenue cycles?
Yeah, when we talk about AI, ML, DL, I mean artificial intelligence, machine learning, deep learning in healthcare. So normally people connected with the clinical domain and not with the non-clinical domain, which is not a fact. In fact, rather I would say that revenue cycle management probably is the main, would a key area wherein this AI and ML will actually make an impact. As I was saying that outsourcing will make a sense or not, and whether the claims period will go up or not. If you will use this AI and ML technologies which are there, in which Western countries are currently using, from this inception, if you use this, then probably this will definitely help you. Why? One of the studies says that the neurosurgeons of New Jersey has used AI in tracking their claims and prioritizing their claim follow-up, and as a result 15% of their AR days has come down, and this has smoothened their revenue cycle management. So the couple of major areas where this AI and ML helps is predicting the denials, from where your denials are actually coming, then patient billing, again robotic process automation and cognitive automation are the technologies which gives you automated alerts about the payers which are giving you the denials for a particular procedures or particular codes. So using this AI technology will definitely help in bringing down the claims, and this is being used in many of the Western companies, healthcare organizations, for reducing their AR period, for patient billings, for complete revenue cycle management, and this has actually resulted. In terms of figures, if I would say, this is estimated that top 10 AI applications in healthcare management would save $150 billion by the end of 2026. And the healthcare revenue cycle AI application software market itself will be of $7 billion by the end of 2020 and $23 billion by the end of 2023. So, which means that AI and automation is increasingly with a very fast and rapid growth it's coming in the healthcare industry.
And do we see any adoption of those kind of technologies, at least in revenue cycle within the industry? Any examples that you would see?
No, see, I would say we were just discussing in the session just before this that leave apart AI as of now, even if we talk about EHR, the adoption is 1% in India. So it's as low as that. However, one of the data I was just pointing out in that discussion also, that the clinician and the healthcare professionals who are using any kind of digital healthcare technology or mobile health apps in India is as high as 88%. And the only country which is above is China, which is using 92%. And otherwise, US and UK are also using 72 to 78%. I mean, their healthcare professionals are 72% of their, or 78% of their healthcare professionals are using this healthcare technology. What it means is that in India, healthcare professionals are keen to use all these technology, provided that they get this opportunity, provided the healthcare organization get that investment in the healthcare, and that is only possible again if the healthcare organization remains healthy and the financial health remains healthy, because the margins are falling down, healthcare margins are falling down for all the nationwide healthcare organizations year on year. And one of the reason is again AR management. So working capital management, revenue cycle management is all connected. These all things are connected with each other, I would say.
Now, so if we have to take, create a very idealistic scenario where the claims are submitted within a day of discharge, okay, because I heard that within 7 days that's the target, but if it has to be within a day of discharge because all the records should be there in place. So what are the changes which the hospitals will require? What are those building blocks which can actually make that possible?
You see, first I would like to go back on this point, what we were discussing earlier about AI, before going further, because I think there's some connection on what points I will be making on these. What Manish just mentioned is about use of AI in reduction of denials and so on and so forth. That's definitely being used in the West, which is outcomes-based reimbursement. In India, outcome-based reimbursement is not yet there. So reality of India is very different than the West. So we also need to be mindful that the RPA is what we call about the simple automation of robotic processes. Also depends on whether the fields that the output that the insurance companies give is in the same place, in the same data format, which keeps on changing. So RPA will only be successful if the stability is there in how the output is given by the insurance companies and TPAs. If that keeps on changing, the RPAs will not work. We at Reliance tried to do an RPA, and it worked for private insurance companies, as I said earlier, because their data science is very based on strong foundations. They come from professional backgrounds, whereas with the public sector company, that's not the case. And also, essentially, because there are a lot of TPAs that are attached to the insurance companies. So they have their own goals and targets. This is the least of their goals as such. So RPA is also, unfortunately, with the TPAs and so-called government insurance companies, is not working as of now. It's not reality. Unless we engage with them and tell them the benefits of having that kind of a productivity enhancement that the hospital can gain out of it. But again, because the labor in India is so cheap, focusing on that is something that is going to be a distant reality for now. That's what I see. So those are some of the real issues that that we at Reliance have been facing and have been going about. And your next question was?
So if we have to streamline the entire process and suppose just take one parameter of days taken or time taken to finalize the claims, and what I heard is it takes around 7 days, and if we have to do it one day, which means the backend systems have to be in place. So what are those changes which are required in the hospital system to make that KPI of 1 day filing possible?
So as he mentioned earlier that reality of EHR also is not there in India. As of now. So until the whole community, healthcare hospitals community is going forward in the mindset that we will do EHR and we will ensure that all the clinical documentation is digitized and on the system, that is not going to happen, because if you keep continue writing with your hand and that handwriting cannot be converted into digital. Nowadays people have started using drag and other applications where they can actually voice their clinical notes and put it in the system. So those applications are also available in the market right now. But until and unless that manual or that voice is converted into a machine readable format, that's not going to happen. So that's what my personal view is.
On this, I would say that a very short and crisp, relevant to the Indian healthcare organization scenario. Until and unless this automation comes into picture, in current scenario, I would say the 3 things which can reduce this pain is: one is your standardized process and checklist, your staff training, and third would be better coordination between clinical and non-clinical staff persons. Because most of the times, this claims when are submitted, it has to be attached with many of the clinical documents, which are actually not, either this billing people are not getting it from the clinicians, or delays that happens there also. So in case there is better coordination between clinical and non-clinical staff has been properly trained, and third is your standard process and checklists are there before the claims are being actually submitted to the TPAs or corporates. That would probably help in reducing the
Dr. Sumit,
Last time. I just to add on to what it can be, I personally feel whatever is tracked normally gets improved. So first and foremost to my mind is, as an organization level, there should be a proper tracking mechanism which is there. Nothing improves if you don't track it. So what I was talking about 7 days, many hospitals does it 80-90% in 3 days. So if they can do 80-90% in 3 days, why not 100% in 3 days? So first and foremost, there has to be drive in the mind that can we do it. Second is, they were saying, yes, I agree with him completely, but if you see a patient goes back home, taking the discharge summary and the billing also. So 90% of the data which we send to the agencies for collecting our credit bills is the same. There are few documents which have to be attached along with it, but why do we take time? Because we recheck it again, because it has to go back to those claiming agencies and we don't want them to be sending us back that particular data saying that this is wrong, that is wrong. That is where I think the IT can help us. It's not AI, but definitely an IT check systems and also alarming systems of saying this is not there, that is not there. Because today we are relying too much on a human training to tell that. And that person keeps changing. Today is with you, after 6 months he is with someone else, then you have to retrain the person. So I think a lot of technology can come for this simple thing to guide us saying that this is not there, these are 10 things which needs to be attached. So then you are moving away from a human training to more of collecting that data and sending it. Third is more important is that if an IT system is there on the other side, today a lot of manual data is being sent. You send them by couriers and all those things. So simple thing like if it can be online uploaded, I think things will become faster. So these are 3 things to my mind which can help us in the simple scenario with the present setup where we are.
Thank you all of you so much, Dr. Sumesh, Manish and Johar, for being the excellent panelists and sharing your thoughts. Thank you so much. Bye-bye.